Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership in Business podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I'm Dr. Micheal Darson, and in today's episode, we will discuss medical practice models, specifically within the academic healthcare system. Joining me today for this discussion is Dr. Stephen Strup. Dr. Strup is currently the James F. Glenn Professor and Chair of the Department of Urology at the University of Kentucky in Lexington. He has been in academic healthcare his entire career, initially at Thomas Jefferson University in Philadelphia, and then on to the University of Kentucky. Welcome, Dr. Strup.
Thank you, Mike. It's good to be here.
Well, thank you again for joining us. So, Dr. Strup, you've been in two different institutions and are likely, as chair, are likely familiar with other institutions and their practice models. I think a lot of people assume that academic practice models are similar. Is that true?
No, I think there's a lot of different models across academics, and a lot of that is due to just different history of institutions, and they've evolved differently and so forth. There's everything ranging from a private practice model, which I'm aware of at several institutions, where they function essentially as a private practice within the academic center. There are others that are fixed salary models. Mayo Clinic and Cleveland Clinic are two large, well-established historical institutions, and that model's been around an awful long time. And then there are some more modern ones, which are the RVU-based ones, which really were initially practice or hospital-based practice models. That's now snuck in, and that's really what ours is. And then there are some that are sort of hybrids of all of these things. So there is no one single way, and at least several that I know of are quite variable.
Talk about the degree of autonomy, because you mentioned kind of private practice models. So I think people assume that there's a lot of autonomy in those type of practices.
Yeah, and I think that's exactly right. I think that the different models will vary based on the amount of autonomy that each individual or the group is given. When you're a private practice and you have run yourself, you make your decisions, and then you're really that you bring that back to the hospital system. That's not always been the case with academics. I think that a practice is going to have the most autonomy. A fixed model may have the least autonomy, other than at least how you interact with the institution. What you do with the resources you're given then may be your only autonomy that you have. So I think when you look at the different types of practice models, at least in an academic center, there are about three things that'll be fairly consistent. There'll be some role of the medical college or dean, because they're going to have a vested interest, and they may interact more on a research front. Sometimes they're the representative of the clinical enterprise, and then the enterprise or institution in general. And so whether that's a private hospital, a hospital complex, a health system, that's going to vary based on where you are. And then the providers are the other arm of that. And I think how they relate are the components of each practice model. And they're going to come together differently. I think the more autonomy you have, the better it is to some extent. But that's going to be variable. And then the last thing I think that can change a little bit with these different models is sort of who's in charge. And again, the autonomy of a private practice is you make your decisions and you decide where you go and how things flow. We can have a great model, but we are not under the illusion that we are in charge of the whole health system. So health systems are the ones that run this, and the medical college can, in certain models as well.
Yeah, it sounds like if a new president of the university or a new chancellor comes in, things could be shaken up a little bit, I guess.
Yeah, absolutely.
Well, let's drill down on the University of Kentucky a little bit more. Can you describe the model you currently utilize?
So we have a funds flow model, and we've sort of traveled through different ones through the years. Our early models were pretty much controlled by the dean, and they were modeled on a practice and cash-based charges and receipts and so forth. And we've evolved a bit to what we call a funds flow model. And actually, it's one that we looked at the University of Alabama at Birmingham. And our president at UK really came from there, and so was familiar with that. And we were looking for a model that brought together these different elements of the enterprise, the dean, and the providers, and really would be something that would work. And so that's kind of where we directed our attention. We didn't adopt their exact model. We made some modifications. It's a little unusual in that, when I sit down and do my budget every year, it's not, okay, here's how many dollars I'm going to generate, whatever. It's here's how many RVUs I'm going to do. So it's an interesting exercise where I have to sit down, gaze into my crystal ball and say, okay, here's what each provider is going to do. Look at the tea leaves. How are they doing? What's going on, with their practice? Are we adding? Are we subtracting, et cetera? And then I come up with a number of RVUs that each individual and our department will generate. And then that generates my budget by being a dollar amount gets fixed to that, often of MGMA dollar amount. And usually it's, just in or right around the 50th percentile. And we sort of resolved on that because one of the issues that came up was, well, how do we deal with downstream revenue? How do we deal with all of these different things? And using that sort of mix of private practice and academic, rates seemed to be a reasonable place to start. It's clearly not perfect because not every area of urology, such as peds and other things, is well covered with that scale. But it gave us a good starting point. And the way it works then is based on number of RVUs I think we can get generated, and then I get a rate that's paid to our department based on that, and then that's divided up by 12 months and paid to us. Now we are responsible for generating that. There are some, where do we get money to pay for things, in the middle? Well, when I have to figure out what I'm going to pay the faculty, then we take the rate that the institution has given us. We take a certain gap out of that may be anywhere from $15 to $20 an RVU. And that lower number then is what we use to generate clinical salary and targets and so forth. The gap, as I call it, is what we use to pay for everything else. And that may be our academic buyout. If you're by rank, you get X dollars to practice and to buy your time for teaching and everything else. Departmental roles, who pays for the administrators? How do we do all that? So all of that stuff comes out of that gap dollar, and how we pay professional development. So all of those expenses sort of roll into that gap. And then it's very clear then what the providers have, what their targets are. And then, if they generate in excess of their targets, then they'll get that same dollar per RVU that was used to generate their target. So it's very clear, what your goal is and how you get there. And if you exceed that, what will happen? So that's the basis of it. We have some autonomy to swing around a little bit to say, well, how do we deal with academics there? We try to have an academic bonus built in. And so we have a whole system of points that rewards papers, grants, participation, citizenry, things that are essential to run a teaching program and run an academic program. And so we have a system that the faculty participate in to help drive production in that regard.
Well, there's a lot of moving parts for sure. How would you, if someone were to pose a question saying, well, why are we shooting for the MGMA 50 percentile? Why aren't we shooting for the 70 percentile? Okay. What goes into that discussion?
Well, a lot of it is that, when you start reimbursing on RVUs, you don't pay anything with an RVU. And so what is that RVU worth, right? And so it's variable. There are some people we'll take care of where the institution's going to lose money hand over fist. That RVU is still paid at the same rate. There are some they may do better if it's a high value procedure, or they have a ton of back end revenue, or OR charges or other sorts of things. There's built-in vagary there. And so the rate seems to set at a livable pace. And it would be wonderful if they want to pay us the 75th percentile. We'd be all about that, right? But it would be hard for them to recoup that. It would be hard for them to recoup that investment because not every RVU is going to be paid at full rate. And so that's why they chose that. I think most systems pick numbers in that ballpark because it allows that allows for those buffers.
So how do you, let's just take two fellowship differences. So oncology versus female public medicine and recon. Obviously, those generate a lot different RVUs based on their specialty. How do you guys address that that specific problem?
So what we do is try to balance out support. Okay, so for oncology, I see 10 patients. I'm probably going to operate on 5 of them. Okay, so our FPMRS team might see 50 to get to that same 5, right? And so how do you generate that? Well, what we do is we just make sure we have more support for the funnel, right? And it's really that funnel. So if we have an APP team that is well trained and subspecialty oriented, that can sift through those initial patients and then get down to the ones that are generated, that's beneficial, right? Mm-hmm. It'd be nice for my lifestyle if I had that same 3 or 4 people generating down just the cases that I do, but it's a way to balance out that, right? So we don't specifically tease out the individual rates or try to break it down based on what people generate, because you can, it may be more difficult, but we work to support your efficiencies, and with those efficiencies, you can see similar numbers of patients. An E&M code is an E&M code, and a procedure is a procedure. You may do things in the office that generate a lot of RVUs that you may not get otherwise, So it tends to balance out. The only specialty we really have to dig out a different rate is our pediatric rates, because they're harder because we've had to come up with some hybrid sort of estimations because the data is just not there for our pediatric urology team, and how they're reimbursed and just getting that data has been hard.
What, that's definitely complicated. How do you, when you're talking about the RVUs and you're talking more to the institution about the bucket of money you're going to get, how do you factor in the downstream ancillary stuff? Like, obviously oncologists are going to use a lot of radiation and their OR again versus the generalist versus the female recon person. How does that factor in?
So that's why we use the MGMA, because some of that from a practice model is factored in a little bit when you look at those models. For us, it depends on how you look at that argument, right? We say, well, yeah, we're generating a lot of these patients that are headed down to radiation and other things. Well, then our family practice could say, but I'm the one that found the elevated PSA and sent that to you for the first place. So where does that end, right? And so how do you start taking the entire institution and try to divide it up by who sent who where? It gets to be exceedingly complicated. So trying to find a middle ground, we actually looked at can you chase that, and it's virtually impossible. Unless you're that isolated practice and you can own your own, things. And so when you look at those rates, they seem to be fair. They take into some of that account. They take in sort of the back end surgery pieces, because there are things that we do that don't generate a lot of margin. Some do, compared to other specialties like neurosurgery and other things. Man, their margin monstrous on some of these cases. Ours, not so much. So it tends to be a pretty good balance, and seems to be at least a very good starting spot.
Yeah, I think if you could unblur some of those lines, you'd probably be the practice chairman of the year. Definitely a conversation that's been going on as long as I've been in practice, for sure. How do you guys get together and decide how you're going to spend the dollars?
So we do it as a team, and that's really helped our transparency, right? And so one of the strengths of our model is autonomy. So we get to decide that, right? So there's nobody that says you've got to spend X or you've got to do it this way or that way. We get to sit down as a group and do that. And then, it's really helped our alignment, because, one of the big words that I had to get rid of is they. Well, they should pay for that. Okay. Well, they should pay for this. Who's they? and when the dean's on the hook for a few things, the enterprise is on the hook for a few things, everybody spends all of their lives going to the different entities trying to bargain for this and bargain for that. It gets real complicated real fast. And then as a practitioner, somebody else should certainly pay for this, right? Well, when it's us and we have that degree of autonomy, we can look at it and say, well, how do you want to spend this, right? So do you want to have more professional development? Is that better for you to go to an extra meeting a year, rather than having an extra, 50 cents on an RVU? How many administrators do you want? Well, the more cost you generate, well, then the wider that gap has to be for me to pay for that. And then I literally throw up our expenses. Here's what we're spending. Most people are like, oh, wow, we spend that much on the residents? Yeah, you do. Oh, wow, we spend that much going to meetings? Yeah, you do. Oh, wow, all those lunches that we want to have? Well, oh, okay. So when people see where the money goes, it becomes real clear, and it helps us be aligned. Where do we want to go? As chair, I basically say, look, here's what I have to do. I got to make the budget balance, right? And I have to have an academic component. We have to be prepared to support that, because people want, I want to do some research. Well, great. Where's your grant? Well, I don't have one. Well, okay, I need money to be able to support those efforts, but there's a price that you pay, because now you're borrowing that money from your partners, right? And so, okay, well, now all of a sudden it's quite reasonable for me to say you have 3 years to work on getting some progress towards a grant. If you don't get it, we're not going to spend your partner's money on you for this effort. So it allows us to look at how we practice and make decisions. My job is to keep those decisions, in line. Hey, I'd like a car. Well, I'm sorry, that's not going to happen. But realistic movements and expenses, how can we help, those that are covering call? Okay, we can do this. Or how do we, we would really like to expand this, or we need to hire another this. Okay. And if we're all looking at that together, autonomy, alignment, those are good things to have happen when you're looking at your budget.
Mm-hmm. So, yeah, I mean, there's a lot of buckets that need to be, that you're dealing with that gap. So let's go back to your example. Say one of the faculty comes up and says, I want to do research, but they don't have a grant. Where does that initial money come from?
So those are the buckets that I feel. So we have different buckets. We have a rainy day fund. So all of a sudden, let's say we get a new president and grants dry up. Like that could ever happen, right? So different things, different forces in healthcare for all sorts of reasons, right? Will come to bear. So if we have some money to allow us to not make dramatic changes in a year-to-year basis, those are good things. The other thing is that, as we've started our funds flow, we're into year 5 now, as we have worked at building those funds, they're very clearly for a purpose. Here is our research bucket. This is the amount of money we have set aside in our reserves to cover unfunded research costs, to pay for a PhD. We want to do this, and this is going to be what it's cost us each year to do this. So we put that money there so we can, if somebody wants to come and do a database, great. We need more stats help, great. Well, I can spend it out of that bucket. So it's very clear that these are research costs coming out of this cash that we've all contributed to, and it's all for the benefit of our department. That's being academic. And so if you're here because you're an academician, it helps us know we're all contributing to this, and it's all part of the things that help our academic success.
So talk some more about the other strengths of your model.
Well, I think it allows us for growth, and I think clarity is important to that. And the other piece is that, the rules are the same for everybody. And so not everybody in this day and age wants to come in. I'm a diehard tail end baby boomer. I work hard and stay late just because I think I should, and I feel rewarded when I do that. How insane is that? But that's okay. That's me. But today, sometimes the rewards are different, and so how do you make judgments? And that was one of my early struggles as a chair, was how do I, answer that question? Don't you value my desire to do this? And the answer is, well, I do, but I don't know how we pay for that. And so here the rules are very clear. You don't have to kill yourself and blow through your target and make a big incentive. You can if you want to. If you don't want to, that's okay too. But it's very clear that it's your choice. And as long as you're meeting your target, it's okay. I value your ability to make that decision. the department's just not going to pay for that, but if you do choose to go over and do and drive, well, then we'll reimburse you a portion of that. And I was fortunate. One of my junior faculty is just a machine, and they're like, "Well, am I hurting you by doing all these RVUs and generating these bonuses?" No, because I get a little bit of that gap every RVU you do, so you're helping us. That's okay. You're not hurting us, and so it really it allows that to happen. Okay. And so I think the alignment is key, giving us the ability to look, and the autonomy is key, giving us the ability to generate that alignment by giving us some control. It's horrible having things come and go and disappear without you having any say in it, because it gives you that, how do I control my destiny? So we know we have some control over our destiny, not complete, but pretty good control. And as long as we're moving in a good direction, we're rewarded for that. And the final piece was that it allows us to sort of take the restrictor plates off some of the salaries. It's very clear how you get to a reasonable salary, and allowed us to get our compensation up to reasonable levels, and I think that it's, those have been the key things that have helped us through this model.
It sounds like is it fair to say that this type of model really, it promotes efficiency?
It does. It's not perfect by any stretch of the imagination, because, you have to be careful how you generate efficiency. Again, RVU doesn't pay for much, right? So when I try to pay my cleaning bill in RVU, they don't take that, right? So, but one of the things you have to be very careful of is expense, right? And so we'll be more efficient. We will generate more RVUs if we hire 5 times more staff, get a much bigger office, and just fill it up, right? Or if you just give me unlimited OR time, you just give me, unless you're paying attention to the back end expense, which is a weakness of this model. Your focus is on generating more RVUs, however you can get that, right? Mm-hmm. And so I think that you can do efficiency because that's the way you can get through and do more RVUs and so on and so forth. So,
okay, well, since you mentioned it, what are the weaknesses in the model?
Well, I think surgeons, by just their mentality, you do what you do for a reason, right? So, we don't like to sit around and pontificate how the world's going to change on this patient's diagnosis and think about it 6 times in round 3. We really say, this is a problem, we need to fix it, we need to kind of go. That's a surgeon mentality a little bit. And as urologists, that's sort of who we are a little bit. And so you put the carrot out there, they'll chase it. That's just that mentality. The problem is that in an effort to get some of those efficiencies, right? So as I tell the residents, do you think I'm a little faster by myself or with you, right? And so, clearly it's going to slow you down to take somebody through a case and to have them sit there and kind of learn and work. But that's why we're here, right? So one of the weaknesses is you're incentivizing speed. You're disincentivizing teaching, because you can do more by yourself or by showing more and having them do less. So, and the academics, do I write a paper or do I put on another clinic? And so you put that carrot maybe in a dangerous spot for an academic person, and you might lose sight of why you're really here. That's part of the reason we try to have our academic bonus and really have ways to reward truly academic behaviors. Because I think if we don't do that, we're just another big private practice, and the teaching will clearly suffer. The other thing is that, we're subjected to the same financial pressures that everybody else is. And so, these models can change, and it's not our practice sitting down and deciding this. This is an enterprise and a dean saying, we've got some new pressures and we're going to lose some back end reimbursement, so that rate that we thought was really good because we're going to get X. Well, now they're talking about cutting this budget and cutting that budget. And no, we're going to have trouble. And so, what your model as it exists today may not be your model that exists next year. And so you're always subject to change and pressures. And like you brought up right from the get-go, new president comes in or new dean comes in, they may have a different idea and they hold a little higher trump card than we do. It's been interesting these last several years that through this model, our productivity as a physician practice has really gone through the roof. Not just in urology, it's really gone across our institution. And so I think they see value in how this works. It's just the fine tuning that's going to create some issues.
Yeah, It's interesting because there's always going to be competing forces, right? So how do you guys balance the wants of the faculty versus what the institution is willing to give? Because like you said, I mean, of course, every provider would want a mid-level assigned to them and to kind of go through their schedule and make them more efficient. But how does that work exactly? That balance?
Well, again, it's, we have a wonderful group of APPs that is, and we've just designed their practice to be their practice. They're not your personal assistant. Okay. So they are there to generate, see patients and generate income. And we have really modeled their practice very much like our funds flow. And so salary-based targets and rewards for productivity and meeting incentives and so forth. So it's allowed us to sort of create that second level of help, but not the personal service stuff. And then, I think it's also, what the institution wants is more, right? And it's my job I think that's my role as chair, is to be that intermediary, to say, stop, I have to balance all of these missions in addition to balancing the budget. So, how do I do that? Well, okay, we're trying to really build philanthropy. Why? Well, if I can create ways to buy down targets through philanthropy and professorships and things like that, well, that takes some financial pressure off. Okay, they don't have to get 12,000 RVUs. They can do fine by doing less because I'm buying down some of that time. So I personally think that's how academics is going to have to survive. We're going to have to find ways to fund our academic mission to take that sort of pressure off our providers, because I don't think those financial pressures and pressure to produce and be efficient, that's not going away.
Well, this has been a really great in-depth look at the University of Kentucky's model. Can you just go ahead and summarize some thoughts on the academic practice models in general?
I think that in general, what works for us works for us. And so I think our model may work well at other institutions, but not every institution. I think that there are certain, time treasured, places, the clinics we've talked about and so forth, that have models that really work well for them. And so it's what you get when you walk in the door, and it's been that way for 50 years. And so, okay, knowing that really helps a lot, right? It's the uncertainty of things that tends to get to us. And so I think that each model will work differently. If you're a private practice that's rolled into a new academic center, and you may function different, you may just contract out services versus just be absorbed into the whole thing. I think if that works for you and it works for the institution, then that's a good thing. Our model may not work in that situation, right? And so I think that each academic model will have those three components of the institution, their wants and needs, the providers, and then the dean or the teaching piece of that. And those will fit together slightly differently in each place. And so finding a model that works, has some history and demonstrated success, that's probably what's going to work for your institution. And it may vary by geography. What works in New York probably is not going to work as well here, right? And so I think that's a big piece of why things work in different places.
Yeah. What would you say to the residents that are getting ready to get out or within a year or so, and they're thinking about joining an academic practice? What important tips would you tell them to look for in a practice model?
I think the first step is, if you're interested in academics and you have a teaching bone that needs to get scratched, you've got something you want to accomplish, remember that, okay? And that you may give up a little something. Maybe that's a few dollars in your salary. Maybe it's this, or maybe it's that. You have to balance everything. Don't forget that while you're doing what you're doing, okay? And so it helps you step back and gain perspective and judge value. I think that's the first thing. Second is to make sure that you know those rules, and that you know kind of how things function. Don't always assume it's all going to be okay, because sometimes it's just not. And so understanding how I get to where I need to get, how are those sorts of things funded? And so talk to your chairman, talk to somebody about how that should work. And it may not work exactly the same based on where you're looking or how those institutions, but there's going to be rules, there's going to be set guidelines, there's going to be ways things work. Make sure you understand them. Don't go in with total naivete, have some business acumen to say, yeah, I'm going into academics, but there's still business rules. We are still a business. We still function. We still have different pressures, perhaps, but understand how those come together in the particular institution you're looking at.
Yeah, those are great words of advice. Do you guys at University of Kentucky, I mean, do you have like a breakdown of how your academic metrics are reimbursed? I mean, if you write a paper and it gets published in a certain journal, I mean, you get X amount for that, or how does that work? I mean, if you really wanted to understand how you do it there.
So there's different ways to do it. We looked at it. Do you have academic RVUs? And so you can chase down a rabbit hole there, and sometimes that works. Actually, our radiology department does some of that, and so forth. What we tend to do is we have a practice plan committee, and we have a 10-point system that deals with academic reputation, our value, quality value metrics, our truly academics, citizenry. So we have these 5 different categories, and then within each category, we have ways that you can earn up to 2 points. And it may be a paper, it may be a grant submission. Okay, if you're doing the work, you don't have to get the reward. If you get rewarded, well, then bam, you get your 2 points automatically. So we have different ways where you get these point totals, and then over all these different categories. And mostly people will do pretty well. We try to set them up so that they're achievable. They don't always have to be a paper in the New England Journal to get credit. If you're writing and you're submitting and you're doing and you're getting residents involved, I mean, those are ways that we say, okay, you generate these points. And then at the end of the year, we look and say, okay, here's your points. We have a distribution. We have the pot that gets divided up amongst the point distribution. And so there tends to be a pretty broad distribution, but it's not super high. The winners win big, the losers get nothing. We try to have it so that we're somewhere in the middle, that production people that are really putting together outstanding effort and so forth get a little more reward. And those that are just kind of touching the bases and doing whatever, well, okay, you get something, but it's maybe not as much. And that's the way we chose to do it, because it incentivizes some, and tries to get everybody sort of walking together. And like our value metrics and stuff, boy, we've got to pay attention to that stuff, because that's how some of our funds are reimbursed based on how we perform on those metrics. And, so if everybody's walking together, you don't have to be the winner at the top of the stack, but if you're not hurting us, you're meeting our threshold, you're meeting our metric, maybe not exceeding by a bunch, well, then you're really helping us, right? So we're all kind of walking together, and that has helped our overall performance for sure.
Yeah, I think one of the important things I'm hearing here is like everybody's on an even playing field. So how you do is kind of depends on how you want to do,
Mm-hmm.
So that sounds really cool. Talk a little bit about, the evolution of healthcare and what you think some of the changes are coming or have come.
Well, I think we're starting to see it. You look at Kaiser. Kaiser has always been an interesting model in my perspective, because they're really that population health. Here's how we're going to manage this population. And all the old school models, the RVU models, are volume-based models, right? You really, you got to crank them through to do well. And I think that model is slowly dying. It hasn't died yet, and that's kind of where we are. But I think we'll have to figure out how we do that differently, when it's okay. We just got to move the needle for the entire population, not by the number of things that we do, maybe by some of the things that we don't do, or what are the right indicators to show that we are making an impact in those patients' lives and in the healthcare of the community. I don't know that we have all of those answers yet, but I think that will change dramatically all of these models, right? Because the whole rules are going to be different. And, just because I did, 500 cases, well, that may be hurting the institution more than it's helping.
Right. Well, thank you, Dr. Strup, for sharing your time and expertise with us today.
Well, it's been my pleasure. I'm sort of fascinated by the whole system thing of things, and from a junior resident to a faculty to now a chair, my perspective has changed dramatically on on rules and finances. I went into medicine because I didn't want to be a finance guy. Well, look where I am. It's a little different. So.
Well, you're using your other expertise, it sounds like.
Exactly.
And thank you to our audience for joining us today on the AUA Leadership and Business Podcast. Until next time, continue to learn, lead, and excel.
Thank you for listening. If you enjoyed this episode, make AUA Leadership in Business your go-to podcast. Subscribe today by searching AUA Leadership in Business on your favorite podcast app and enhance your leadership and business education needs.